Welcome to the deep dive. Today we have something really unique. We've been given the full clinical textbook, Advanced Skin Cancer, a case-based approach, which really reflects how top-tier centers are managing these complex cases right now.
That's right. And our mission today for you is to really distill that. We're going to pull out the core principles for diagnosis, for staging, and therapy, especially for these advanced cancers.
And it seems like the whole approach has changed.
It's completely different. We're in what some people are calling an oncology renaissance.
Yeah.
The new systemic treatments have just revolutionized what's possible.
Okay, so let's map this out for everyone. We'll start with the most common ones, melanoma, squamous cell, and basal cell, to really nail down the fundamentals.
And then we'll get into that renaissance you mentioned, the systemic therapies. After that, a look at some of the more specialized areas like cutaneous lymphomas and even some really rare tumors where new tools are making a huge difference.
Perfect. Let's start with melanoma. I mean, the numbers are just staggering. It's responsible for over 90% of all skin cancer deaths.
It is, and the incidence just shot up something like 270% between the early 70s and the early 2000s.
So what's the key risk factor we should be focused on? It's UV radiation, obviously, but there's a nuance there.
There is, and it's a critical one. It's not just about chronic day-in, day-out sun exposure. The higher risk actually comes from intense intermittent exposure.
You mean like those really bad blistering sunburns?
Exactly. Those are statistically a much bigger deal. And you also have to consider the racial nuances. While white populations have a higher risk overall for acral melanoma, the kind on palms and soles, the rate is actually equal across all racial groups.
And that's the most common type in Black populations, right?
It is. So for diagnosis, we're still looking at the classic ABCDs.
Asymmetry, border, color, diameter, and I think the most important one, evolution, any kind of change.
Absolutely. So once you have that diagnosis, you move to surgery, and the margins are very clearly defined.
How so?
For thin tumors, so 1 millimeter or less, you're taking a 1 centimeter margin. If the tumor is thicker than 2 millimeters, that margin doubles to 2 centimeters.
That feels like a lot of tissue to remove. Which brings us to the lymph nodes. When do you decide to do a sentinel lymph node biopsy, the SLNB?
The guideline is for tumors 0.8 millimeters or thicker. Or, if it's thinner but has ulceration, you'd also proceed.
Okay, but the really big shift in thinking comes after that biopsy, if it's positive.
Yes. The old way of thinking was that a positive sentinel node automatically meant a completion lymph node dissection, or CLND.
And that's where you go in and clear out the rest of the nodes in that basin?
Precisely. But the MSLT2 trial data completely changed that.
What did it show?
It was profound. It showed that doing that huge extra surgery offered no overall survival benefit.
No survival benefit at all.
None. All it did was improve regional disease control, but at the cost of, major complications like lymphedema. So now the thinking is to favor systemic therapy with close surveillance of the nodes instead of more surgery.
That is a massive paradigm shift. Okay, let's move to the second most common, cutaneous squamous cell carcinoma, or cSCC. This one's more aggressive than BCC.
Much more. Once it gets to the lymph nodes, the 5-year survival just plummets down to around 26 to 34%.
So identifying the high-risk ones early is critical. What are you looking for?
Clinically, you're looking at tumor size, location, especially what we call H areas, like the central face and ears, and whether the patient is immunosuppressed.
And under the microscope?
Histologically, things like poor differentiation depth over 6 millimeters, or if it's invading nerves or blood vessels, those are all major red flags.
And I guess the old staging systems weren't good enough at catching these high-risk features.
Not at all. That's why the Brigham and Women's Hospital, the BWH system, was developed. It's much better at predicting who actually needs a nodal biopsy. For their high-risk groups, the T2B and T3, the chance of a positive node is as high as 35%.
So it lets you be much more selective. Okay, let's round out the big three with basal cell carcinoma, BCC. By far the most common cancer, but very low risk of spreading.
Very low, yes. We're talking less than 0.5% metastasis risk. But that doesn't mean it's not a problem. The local recurrence can be high, especially with certain subtypes.
Which one are those?
The micronodular, basisquamous, infiltrative, and the sclerosing or morphiform types. For those, you need really tight local control.
And for that, the gold standard is Mohs surgery.
It is. Mohs surgery gives you a 1% 5-year recurrence rate. Compare that to over 10% for a standard-wide excision on a high-risk tumor. The difference is huge.
But for a simple, low-risk BCC, you don't always need to do surgery.
Correct. You have other options like electrodesiccation and curettage, photodynamic therapy, or even topical creams like imiplimumab or 5-FU.
All right, that covers the local management. Let's pivot now to the systemic therapy revolution. This is where the story gets really interesting, starting with melanoma.
Absolutely. The main weapons here are the immune checkpoint inhibitors. Drugs like ipilimumab, nivolumab, pembrolizumab. They basically take the brakes off the immune system.
And the data shows that using them in combination is more effective.
It is, but there's a big trade-off.
Toxicity.
A huge increase in toxicity. With combination therapy, the rate of severe, grade 3 or 4 immune-related adverse events jumps to 59%.
59%. Wow. What
Right.
does that actually look like for a patient?
It can be serious.
Mm.
We're talking severe inflammation of the bowel, which is colitis, or the liver, which we call transaminitis. The cases in the book even mention things like dramatic hair whitening, called poliosis, and permanent problems like adrenal insufficiency.
So it's a powerful tool, but one you have to manage very carefully. Now, for some patients, there's another option-targeted therapy.
Right. For the roughly 50% of melanomas that have a BRAF mutation, you can use a combination of BRAF and MEK inhibitors.
And what's the key takeaway there?
The speed. I mean, the response is incredibly fast and dramatic. You'll see lesions shrinking within a couple of weeks. It's remarkable.
Let's apply that systemic thinking to BCC. For advanced cases, you're targeting something called the hedgehog pathway.
Yes, with a drug called vismodegib. It was the first one approved, and it targets a protein called SMO. It works well initially, an objective response rate around 60%.
And there's a catch.
The catch is resistance. It's almost inevitable, usually within 6 to 8 months.
And we need to understand why. How does the cancer get around the drug?
The pathway just reactivates itself, but it does so downstream from where the drug is working. You get mutations in other parts of the pathway, like GLI2.
So the crucial clinical takeaway is?
You cannot use vismodegib by itself and expect a cure. It's not a curative monotherapy.
So how do you use it effectively?
Strategically, you can pulse the dosing for patients with Basal Cell syndrome to make it more tolerable, or you use it before surgery or radiation.
Why before radiation?
Because it acts as a radiosensitizer, it makes the radiation work better. But you always have to be managing the side effects, the muscle spasms, the hair loss, and dysgeusia, that really debilitating loss of taste.
And just as they revolutionized melanoma, these PD-1 inhibitors are now being used for advanced squamous cell carcinoma?
Yes, drugs like imiplimumab have been a huge advance for unresectable cSCC. You see response rates around 47%, and it's often well tolerated, even in older folks.
And there's a specific pitfall clinicians need to know about with these drugs.
Yes, the concept of pseudoprogression. This is so important.
Explain that. What is pseudoprogression?
It's when the tumor looks like it's getting bigger on a scan. But it's not because the cancer is growing. It's because the immune system is flooding the tumor with inflammatory cells and causing swelling. It's actually a sign the drug is working.
And if you don't know that, you might stop a treatment that's actually helping.
You'd stop it prematurely, exactly.
What about the very specific challenge of using these drugs in an organ transplant recipient?
That's a high wire act. There's a 40 to 45% risk of rejecting the organ graft if you use a PD-1 inhibitor. So you have to try and switch their immunosuppression, ideally to a drug like sirolimus, which has some anti-cancer properties itself.
Okay, let's change gears completely and talk about cutaneous lymphomas. These are a whole different category of skin cancer.
They are. The T-cell lymphomas, or CTCL, are mostly mycosis fungoides and Sézary syndrome. For MF that's widespread, the main tool is total skin electron beam therapy, or TSEBT.
And the sources emphasize using a low-dose version of that. Why is that?
Because mycosis fungoides is a chronic, incurable disease for most. The goal is long-term control with minimal toxicity. A low dose of 10 to 12 gray can be repeated over the years, whereas a full dose of 36 grays really can't be.
What about systemic therapy for CTCL? There's a drug called brentuximab vedotin.
Yes, and it's fascinating because it targets CD30, but it works even if there's very little CD30 on the cancer cells. We see responses in patients with less than 10% positivity.
That is counterintuitive. What's the main side effect to watch for?
The big one is peripheral neuropathy. It affects a majority of patients, so you have to monitor for it constantly and be ready to adjust the dose.
Now, for the B-cell lymphomas, the CBCLs, prognosis really dictates the entire approach here.
It's all about indolent versus aggressive. The indolent types, like PCFCL and PCMZL, have a fantastic prognosis. Local radiation gives 98% control. For widespread disease, rituximab is very safe and effective.
But the aggressive type, primary cutaneous DLBCL leg type, is a much scarier diagnosis.
It is. The 5-year survival is less than 60%. The standard of care is full RC-HOP chemotherapy. But for an elderly patient, that could be very tough.
So what's the alternative?
The alternative is Armini-Chutopi. It's a dose-reduced version that improves tolerability while still providing a good, acceptable level of efficacy for that population. It's a quality life decision.
Let's move into our last section, covering the rare but important tumors and some of the really advanced surveillance tools being used. Let's start with Kaposi sarcoma.
With KS, it's all about the cause. Every case is linked to the HHV8 virus and the patient's immune status, so you treat the cause.
So for a transplant patient who gets it from their immunosuppressant drugs,
The first thing you do is change the drugs. You switch them from a calcineurin inhibitor over to an mTOR inhibitor like sirolimus, which actually fights the tumor through its anti-angiogenesis effect.
and what about DFSP, Dermatofibrosarcoma Protuberans? It's known for these finger-like projections that make it hard to remove.
And we know exactly why it does that. 90% of cases are driven by a specific genetic fusion, COL1A1-PDGFB. This creates a feedback loop that drives uncontrolled growth.
So if you can't cut it all out, you target that pathway.
Exactly. For unresectable disease, you use a tyrosine kinase inhibitor called imatinib, which directly blocks the receptor that fusion gene is overactivating.
Okay, now for what might be the most exciting tool in the whole book. Monitoring for Merkel Cell Carcinoma, or MCC. It's rare, but incredibly aggressive.
And we can now monitor it with a blood test. This is a huge leap forward. About 80% of MCCs are caused by the Merkel cell polyomavirus.
And you can test for antibodies to that virus?
Yes, the MCPyV oncoprotein antibody test, or AMERSEC, you get a baseline level. For patients who are positive, you recheck it every 3 to 4 months.
Why is that blood test so much better than just getting a PET scan every so often?
Because a significant rise in that antibody level has a 99% positive predictive value for recurrence.
99%.
It's an incredibly sensitive, real-time alarm bell that tells you it's time to get imaging. It finds recurrences much earlier. Seronegative patients, on the other hand, have a higher risk from the start and need regular imaging anyway.
That's a true game changer. So finally, we see cases where clinicians are combining therapies for the toughest situations.
Yes, like in a basal squamous carcinoma case. They used a combination of vismodegib, the hedgehog inhibitor, and pembrolizumab, the PD-1 inhibitor.
So you're blocking the tumor's growth pathway and stimulating the immune system at the same time.
Exactly. You're hitting it from 2 different angles. It shows how personalized and creative the field has become.
So after all this, what's the single biggest message you think our listeners should take away?
That there is no one-size-fits-all approach anymore. The management of advanced skin cancer is this incredibly personalized synthesis of the patient's own factors, their age, their health, their life goals, and the specific molecular biology of their tumor.
It's a constant balancing act.
A constant calculus, weighing the efficacy of a treatment against its toxicity and the patient's quality of life. We saw that with Mohs versus radiation, or RCHOP versus Armini-CHOP. It's about tailoring the very best plan for that one individual.
A fantastic summary of a complex field. Okay, to wrap up, here's a final thought for you to chew on based on everything we've discussed today.
Okay, think about this. In managing locally advanced basal cell carcinoma, we know vismodegib works well at first. But when that patient develops resistance, what's the mechanistic reason that just switching to another SMO inhibitor is probably not going to work? And thinking about that pathway, what type of drug would be a smarter next step?